Yeah, hello. Sir,
Yes, Srinivas.
yeah, good afternoon, sir. We are able to,
Good afternoon, Srinivas. Welcome to Cath Lab NIMS.
yeah. We are able to see you and hear you.
Yeah.
We'll just take a minute just to show you, because you are the first person to do demonstration with
Yeah.
this new 360 degrees camera which is placed in front of you, I think.
Yeah,
I
yeah.
think where we get a feel of entire cath lab. But before, that is a thing where you can capture the entire camera. If you zoom it further up, then entire lab is seen. If you want to go close, you can show it. You can remove the zoom totally so as to see the entire lab.
Okay.
We have been working with this for some time, and then all the aspects of the lab are seen. Maybe on the bigger screen you would appreciate it better. And the no technicians are involved. Only one 360 degrees camera which captures all round this. This is what is required. We are there further. We have to refine it further. We have been working with this, and whenever we feel it is optimal, we'll further highlight those aspects of it. I think you can show your case.
Yeah.
We have, sir, Dr. Seshagiri Rao, we have Dr. Sushil Kodali, Dr. Juan Pinto, Dr. Ramesh, Dr. Praveen Chandra, and Dr. Gopal Murugan with us, and Rahul Potlovi.
Welcome to all.
Yeah.
This is Nizam's Institute of Medical Sciences. Here we have our team. Dr. Shivaprasad is there, Dr. Srikanth is there, Dr. Gopal is there, and other technicians and staff nurses. Here is a lady, 76-year-old, presented to us with significant angina. She has calcific lesions in the LAD and LCX. One interesting thing is in her, the RCA is very small. Only there is a conus branch that is seen. You can show the patient data. Only the conus branch is seen there. The rest of the RCA is missing. We did a CT also. CT did not show any vessel in the right sinus, but PDA is filling from the LAD. So the CT person, the image all this said the PDA is coming from the LAD part of it, but PLVB and other things are absent. So we are wondering whether it could be a congenital absence of the RCA, which can occur in 0.2 to 0.6% of the cases. You can see the CT there. The LAD is curving around the apex and giving a small PDA there. And here actually both LAD and LCX both are very significantly calcified. You can show the angiogram.
Our angiogram?
Yeah. These injections you can show. Yeah. You see the calcium extending from almost ostium of the LCX and LAD, both are having very tight lesions. There are two lesions in the LAD, the ostium is tight and also mid segment is tight. And LCX, there is a long segment calcium with a very tight lesion. And one OM is originating from the LCX there opposite the lesion. So our plan is to basically rotablate this calcific lesion in the circumflex first, because she has a significant angina and ST depressions in lateral leads. The moment we put her on the table, patient started having angina. So we quickly engaged the left main and crossed this thing with a microcatheter in the Cougar wire. And once we remove the microcatheter, once we remove the Cougar wire, we put the rotablator wire. You can show the next. Yeah, this is the rotablator wire. And so next. So we ablated the plaque with a 1.25 bar. Yeah, actually we wanted to take an IVUS run before doing rotablation, but patient was having significant angina and the lesion was also very tight. We thought probably it won't allow the IVUS catheter to go in. So we ablated the plaque and later dilated with a balloon. Yeah, next. So this is a 3 mm balloon, 3 into 12. And next, approximately also we dilated. Next, so one more inflation more proximally. We did not want to dilate the ostium because ostium was reasonably all right, but some plaque is there. But this is the injection after dilatation. We wanted to protect the side branch. We put a wire into the side branch, obtuse marginal, And you notice a big dissection there on the inferior margin of the circumflex after the balloon inflation. So next. So then we took a IVUS run. So this is the IVUS catheter volcano that is going in. Next. No, IVUS, yeah. Show the IVUS run. Yeah. You are seeing the IVUS?
Yes.
Hello?
Yes.
Yeah. Yeah, this is the distally the vessel looks about 3.2 and at the site of the lesion is very tight. Yes. So there is a calcium that is seen. Here there is almost circumferential calcium.
So that was after a 1.5 burr?
Yeah?
It was a 1.5 burr that you used, or
Yeah, 1.25.
1.25?
Yeah, yes. So actually here initially we thought the vessel could be maybe around 3, but here vessel looks a little bigger. So go back. Yes, proximally it looks more almost 3.5 to 3.75 vessel, and there is a soft plaque at the ostium of the LCX. So after taking this IVUS, we thought we would stent that area with a 3.5 millimeter stent, which is 32 millimeters, 33 millimeters long. So this is a 3.5 into 33 stent.
Perhaps before we go further, it's worth a discussion.
Yeah.
Based on that IVUS, would anyone have rotablated with a larger burr? Did you feel comfortable that you had complete expansion? Would people have done anything different?
I think I would have taken a larger burr in this particular patient with that I was findings.
Yeah. No, we also thought like that actually after this thing, small dissection was noticed that was actually increased after balloon dilatation. So we thought we would dilate with the balloon and see how but it yielded well with the balloon. Balloon has inflated very well. So that's the reason we thought we would go ahead with balloon inflation and later stenting. So this is a 3.5 millimeter stent, which is almost across the OM. OM is squeezed a little bit. And proximally the ostium shows some block, some lesion there, maybe about a 30% lesion at the ostium. And after the dilatation of this vessel, after stenting this vessel, we took an IVUS run again. We'll show you the IVUS run.
Okay.
Yeah, this is after stent.
Yeah. So show us the IVUS of the ostium circumflex.
Yes.
IVUS, please. Yeah.
Yeah, another strategy, and sometimes in vessels which are more than 3.5 or 3, what one can do is after doing a rotablation, one can use a cutting balloon of 3.25 or 3.5 size or angiosculpt and then go ahead with the stent after that. So that may lead to better expansion in the stent.
Yeah, Praveen.
Yeah.
But here it has yielded very well with the balloon.
It has worked very well for you.
Yeah. So that's the reason I thought we would go ahead with stenting.
That's right.
IVUS, please. Yeah.
Yeah, but right at this point, the stent looks under expanded. I don't know what was the minimal stent area in that area.
Minimal stent area is almost 6 square millimeters. This distally it is about 8.
No, stent.
Was that a 3.5 stent, did you say?
3.5 stent, yes.
33.
Yeah. So this is, it is about 6 square millimeters. So we thought it's dilated reasonably well.
7.
And apposition is also quite good. So, more proximally. In general, for a 3 millimeter vessel, the area, stent area should be minimum 6 square millimeters.
Yeah, but
Yeah.
right now, that point is 5 point or less than that.
Yeah. This. So what is your opinion? You need to go with a further expansion of the stent, or we'll leave it at the juncture.
I would expand. I mean, the data supports more than 6 millimeters. I think that there is a place where proximal to the OM1 branch, about maybe 10 millimeters proximal, even on angiogram, it doesn't look well expanded.
Okay.
Play.
And we still haven't seen the ostium of the circumflex.
Yeah.
What is the minimal area over there?
Show the ostium on the L6. Here the ostium it is around 5.8 to 6.
So what is your plan for the ostium? You want to do it or leave it?
I think we can leave it because the area looks pretty good, almost 6. It's 5.9 at the ostium.
Then I think it's okay to leave it.
Yeah. So about this thing, stented area, I think you need to dilate further. Already dilated with a 3.5 balloon up to 14 atmospheres.
I would go with the 4 non-compliant balloon in that area.
The area of the lesion.
Area of the lesion.
Yeah, right.
Certainly the place where you had dumbling of that previous balloon, you can give it another whack there with high pressure, because the vessel diameter is clearly 4. So you can even put a 4 non-C and go to 20 atmospheres, because there's plenty of room, low risk of rupture.
Yeah. Only this concern is that it might close out that OM. OM is already squeezed. So if you dilate that area further, there is a chance of closing down the OM there.
I agree with you. I think you need to dilate just a little bit proximal to that OM and leave that OM.
But perhaps a short balloon may not impinge on that OM, because I think that you have a little bit room, probably about 15 millimeters from...
And remember that OM is actually quite a big branch. So are you going to re-enter and then dilate the ostium, or?
That's the reason why we thought we would leave it at that juncture, because any further dilatation might close down that OM.
Yeah.
Okay?
I think that's a good, reasonable thing to do.
Right.
Yeah. I think now we'll go ahead with LED. So LED is again having a lot of calcium from ostium to the mid segment. Epicranial.
I would still keep the wire in the circumflex, because you might have to do almost come back up to the ostium of the LED or even into the left main. I see that.
Yeah.
He is planning to do a rota to the LED as well.
Yeah. We'll have to do the rota to the
N wire with the microcatheter.
microcatheter with the wire.
So for the LED, I don't think, do you routinely use microcatheter? Because personally, I would just go straight ahead with the rota wire.
Rota wire, yeah. But in general, our thing is that basically we are more comfortable with going with microcatheter.
That's all.
But when calcium is there, a lot of calcium is there, there is a chance of thinking the rota wire all this. So that's the reason I mostly will be going with microcatheter and then put a rota wire.
Right. I think both
both ways.
approaches are okay.
Yeah, but let me tell you, in typically very, very difficult situations also, rota wire is quite actually easy to maneuver.
Yeah. You would prefer a rota flexible wire or extra support wire?
A flexible wire, preferably.
Because when calcium is there, a lot of calcium is there.
Yeah, I think to avoid bias, I always use rota floppy, which is I think rota flexible wire you're talking about.
Rota floppy is the usual one.
Yeah. But circumflex you use rota floppy only.
I like the Rota XS when you're dealing with the LED and it's straight. There's a little bit less of a problem when you bring the Rota through the guide. But other than that, we use the Rota floppy for almost every case, especially when there's tortuosity.
Yeah.
Press. Yeah, whenever the vessel is more tortuous, I think flexible wire may be more advantageous. What do you think?
I think it's really down to individual preference. I use floppy wire in majority of the cases because I'm really worried about wire bias.
Okay.
I'd rather have the rota wire go the way the wire is rather than try and force against anything. So if you have a stiff wire, there is a small chance you may have a wire bias, you may cut through a corner, but if you have a floppy wire, you wouldn't. So, and because Rhoda anyway, it's differential cutting. It'll only cut the calcific plaque anyway. So even if it wobbles around, doesn't matter. So I prefer a floppy wire for that reason, unless it's another reason.
Yeah, so basically 99% of the times you are okay with a floppy wire.
Yes. Yeah.
I think we'll have to increase the curve of the wire. I think it's already more angulated there.
Are there any other atherectomy devices available in India?
So come again?
Are there any other atherectomy devices available in India besides rotoblator?
No. It's just rotational atherectomy, and that's it. There's no laser yet.
Yeah,
So-
orbital is not here.
Sushil, you are talking of orbital atherectomy?
Yes.
Yeah. So,
Laser is here.
Laser.
Laser is not.
No, I mean,
Laser, I mean, it was still not available with us, and now we're just going to start the initial study, which is 100 patient study with lasers, but that I think is a option in these kind of situations, certainly. But orbital atherectomy we have done, we did the Orbit 1 trial initially, and it is a reasonable device in these kind of situations. But after that, it is not available in India as of now. But you all must be having it there.
Yeah, we have orbital.
So would you use it in this situation?
I would use either in this situation or mostly actually in left mains. It is very helpful because earlier we were talking about left main rotor. Even a 2 burr may not be enough at times. I think whereas orbit will be giving you a little bit more atherectomy area. That said, one comment about differential cutting. I truly don't agree with that in the sense that I don't believe in it. Because if truly every device is differential cutting, we should never have any perforation. Whether it is orbital or with rotor, we still have perforations. Even with orbital, the higher the speed that you increase, you can actually go into and do atherectomy in a 5O vessel. But that will cause more chances of perforation.
But I think there's some differences based on the individual anatomy, right? Because orbital atherectomy often shaves, and so if you have a deep circumferential plaque, it doesn't provide the crack you need to expand with the balloon. In those scenarios, sometimes the rota stiff wire and sometimes it almost feels like a notch in that calcium that allows you to expand. And I think rota is better for doing that in certain scenarios. I've just, with orbital, sometimes it seems to be shaving equally, and you still have that inability to expand, and you don't get that differential cut in one side.
I did a few cases of rota, maybe we did about 30 or so, and then my feeling is that orbital atherectomy is like a softer rotablation system compared to rotablation, which is like, it can pierce through anything. But with that olive-shaped device, it'll be a little difficult to move into very tight lesions and very long calcified stenosis.
I think also coming back to laser, I think it's particularly very helpful in cases of ISR. But I think in this case, trying to get a laser down that calcified vessel is going to be a little bit difficult.
I think it's really down to the atherectomy device's properties. When it's calcium, it's clear Bondo calcium. Laser is bad because laser is not good for calcium. Laser is good for a soft calcium or a fibrocalcific plaque. But if it's Bondo calcium, laser just doesn't cut. You need a drill. But I guess in routine patients where the balloon is not expanding, you already have a wire, then laser would be good, like instant restenosis, or perhaps in acute MI where you want to sublime the thrombus. Laser is great, but perhaps not for Bondo calcific lesions like these.
But I think for that deep calcium that Sushil was talking about, laser can be an option when you use it with contrast and try to see if you can get a little bit of a deeper cavitation.
No, that's a good point with contrast, but I think you have to be cautious with that, and that's sometimes, you can create a lot of harm with that as well if you're not careful. And all of these atherectomies, I think the challenge is the devices have gotten so good, the balloons are so good, that we use it less and less. So the inertia and the threshold, to, at least in the U.S., to do atherectomy is high. And so the people are not very experienced. Our fellows as well, you know, we use less and less atherectomy.
No, I think the fellows actually separately keep track of the amount of rota cases that they do. It's like they get to see a unicorn when they do rota case. But I will say also too for atherectomy, when you're doing a CTO case and the vessel is dissected and calcified,
You want to check?
I often will feel a little bit better
Sir,
about doing atherectomy in the subintimal space with a laser than with the rota.
Clip it.
Yeah, here we are going
Have
with
you-
1.25 bar.
Have you guys had experience where you use a large large French guide, and then you bring the use a guide liner to deploy the laser, pass the lesion, and bring the laser back to debulk rather than going forward?
Sir, check chair. Rotations check chair.
I'm sorry, I couldn't hear exactly what you said.
Sorry, I'm saying because obviously laser is sometimes difficult to pass through a calcified lesion. I was told some people are using a large French guide, putting a guide liner, making sure they get past the lesion and then laser on the way back rather than passing the probe forward.
So I actually think laser is weaker than orbital atherectomy, in my opinion, if you think about atherectomy devices. But that said, there is no comparison clinical trial. So it is my own perception that rota cuts better than orbital atherectomy and then probably laser. So I think if you have a thick amount of calcium, it's probably better to choose rota in that scenario where you can't actually pass any device, a balloon, or there's no, we are struggling to use a guide liner to deliver a laser and bringing it back, whether it adds any true atherectomy, I'm not sure. I think that said, if you're doing that type of patient, you should follow up pre and post IVUS, pre and post laser IVUS would be helpful to know whether that is working or not. So Dr. Seshagiri Rao, we are back with you and we are discussing about different atherectomy devices while you passed a wire and you exchanged it for the rota floppy.
Yeah.
And now you're going back with 1.25 rota burr, right sir?
Yeah, 1.25 bar.
What are people's first choice for burr size? I tend to always start with a 1.5.
Yeah,
and not use-
1.5 seems.
Yeah,
what we
here
do
the
too.
arteries are a little smaller. That's the reason I mostly will be going with 1.25, and if it is needed, we will upsize the bar later.
I rarely use the 1.25 because we've generally had this rule of 0.8 or less ratio to worry. And then also too, the 1.25 burr is shaped a little bit differently than the 1.5 burr. It's a little bit narrower and more like a watermelon seed. And it has, I think, a little more risk of going into and past the plaque and then not being able to come back out. So for that reason, I tend to avoid the 1.25 burr.
So I base it on the severity of the lesion. If it is very tight, I go to 1.25. If it's not, I go to 1.5 because even in the United States, each burr is expensive.
Yeah, but the concept of just modifying the plaque with a 1.25 and then use a balloon to dilate the lesion further also works pretty well, as he is doing in this case. Yeah.
While doing this, actually, we have to pay attention to the wire not to be drifting back as we are seeing.
Wire is a little bit drifting back.
Right.
Advanced wire.
I also do shorter forward passes and a little bit slower. So, kind of tap it forward and then just slowly advance it, slowly come back. And then when I come back, it's on Dynaglide. Actually, when I come back into the guide after I've pulled it back, rather than
Also saw the burr stop halfway through. I'd be nervous with that. I'd drill it all the way back.
I agree with that. I think the worst scenario is getting that stuff.
Yeah, here there is a dense calcium. Actually, it's not passing through the lesion here.
It's quite dense right at the proximal segment, and I'm surprised it went right down and then came back.
Yeah, initially it went down and it came back.
This is, I think, one of the things which is very, very
So I would try to get
dangerous.
the wire a little bit
Yeah.
farther down and not stop the burr in the lesion.
Yeah.
Yeah, yeah. You should not stop the burr in the lesion. Yeah. Ready?
Is there something going on with the wire and the brake on the back table? Because the wire's moving a lot.
Is
Is
there a
the
brake
brake-
on the wire? The assistant should be very careful with the brake and also try to advance if it's coming back while doing the rotational atherectomy.
And you might want to move the brake closer to the manifold thing.
And you need that wire sitting much deeper if you can.
The advantage is the floppy wire, the tip is very good, but at the same time, sometimes you can suddenly, the rotor can go beyond that and break the wire.
Rotate this thing. Rotate the wire and go forwards. Yes.
Kinking it is. It is kinking.
Have you
No,
ever had
what happens is that once
have to push on the black
bar
button
is
in
there,
order to advance
it
the
becomes
wire.
very difficult to push the wire. So while rotating, it is very easy to push the wire inside.
Yeah, that's what. With rotation, I think we'll be able to. But
Yes.
here we are trying to rotate. Yes. That's going a little bit in.
No, what Dr. Praveen Chandra is saying is while burring, while doing the
burring you can do
atherectomy,
it,
advance the wire.
Yeah.
Or if you're very proximal, you can always go on dynaglide. If you go on dynaglide, you won't ablate, but you can advance the wire.
Yeah. When it is touching the plaque, actually wire is coming out because it is not able to go through the densely calcific area. But initially it went in once, but subsequently.
Just be patient. Just be patient.
Quite a lot of ectopics. Check your wire position because there's quite a lot of ventricular ectopics on your ECG.
Take my
Yeah.
Can you pull it out and do an angiogram just for sake of
Yeah.
education,
Yeah.
or at least into the guide?
Ready? Injection, please.
Yeah, good pressure, good pressure.
Make sure there's
Ready?
no air embolism.
Yes,
Yeah,
sir.
yeah. Go.
Okay. So that
Yeah, the reaction is a little tortuous also.
Right,
Dense
right.
calcium there.
so that
lesion
lesion definitely has not been.
So I would just really check the system and make sure that your white brake is on the wire and close to the burring mechanism, because the wire seems to be moving a lot forward and back. And then I would just be patient. It's going to go through. It always goes through.
Yeah.
Yeah, and just sort of more pecking motion, sort of at the lesion and sitting on the lesion and then coming back may be helpful in this scenario. I think doing all of this, I mean, the one thing to keep in mind is you've done rota in the circ, you've got microvascular debris in the circ, you're ischemic in the circ, you stented. Now you're doing rota in proximal LAD, you're going to embolize distally, and you're going to get microvascular embolization, and you're going to get ischemic. And I think the issue of ectopics and the hemodynamics, I noticed the pressures have been in the 80s, is to be cautious and be patient and make sure that the hemodynamics are okay.
Yeah,
Because you've stressed this heart quite a bit at this point
Saline.
with a lot of rotational atherectomy. So I would make sure, as Kirti said earlier, sometimes do it, wait a minute. Sometimes you give a little burst of neo before you start your rotor run, do shorter runs, and those type of things as well.
Not going further.
Yeah, we're waiting for the patient to settle down because she has some angina also.
And I would suggest actually, if you need to get the burr out and position that wire much more distally and use a fine cross or whatever microcatheter to do that if necessary.
Dr. Seshagiri, can I ask, is
Yeah,
it the
yeah.
same burr as the circ burr that you used?
Yeah, same burr, same burr.
Because one of the things, because with all the burring that you may have done, the diamond end may have gone blunt also, worthwhile considering. If you
Yeah,
feel,
we are also thinking on those
I
lines.
don't
I think
think
we
so.
need to go for a new burr.
Yeah, probably. I'd
Yeah.
position this wire and
We'll try once more and see, otherwise we'll switch over to a new burr.
sounds good.
Ready?
Yeah, before
So you
going
mean
to a
to
new burr, I would actually position the wire as
Position the
Rahul
wire,
is saying that,
Yeah, yeah.
and try this again.
Can you go in one
Because I thought the burr is good enough for at least 5 or 6 patients.
Yes, yes, absolutely.
Yeah, yeah. We're doing
Yeah,
four,
but
five
that,
patients.
what Gopal is saying is does happen with reused burrs.
Right, yes.
But in the same patient, same time, I don't think that should be a problem.
I hope the burr was.
Yeah, sometimes there will be some problem with the gas libers because we'll be using on 4 or 5 patients, no? Well, after gassing, they sometimes will
Yeah.
have these problems, but Uber, as you said, there shouldn't be any problem.
Yeah, this is the New York
We
burr.
went, sir.
Sorry?
Yeah, we went sufficiently good distance.
Now, patients now know New York and stuff. So I'd be very, very careful using those terms.
I would try and keep the burr a little bit longer at the lesion rather than coming back so quickly. Let it sit at the lesion, not pushing forward, but let it sit right at the lesion maybe.
I wouldn't pull the burr back, actually let it play right there in the mid lesion rather than withdrawing
stay there
completely.
for
Stay there.
20 seconds.
Slower movements, I think.
Yeah,
forward
slow
and then
pecking
back.
motion.
Fluoresce, okay?
Still, I think you are not able to cross that area, but initially...
You know, I will still suggest that you better position the wire more distally, then you'll have good support. And then
Take out the wire, rubber.
Yeah, use
try to do that with a
Take out
slow
the burr
pecking
and-
motion.
Yeah, position the...
Then Glina,
Listen,
Dina.
take on Dyna. You are taking out the burr and you will reposition the wire.
Wire, check your wire. Okay, now you
Yeah,
went
that's
distally.
better.
Yeah.
That's better.
That's
Perfect.
Yeah, that is the way, because once you rotate it, it moves inside.
It go now?
Now check that brake is working.
I think that just demonstrated how Dynaglide can help pass
Yeah.
the wire, advance the wire forward.
Yeah, that's what you were saying, yeah.
It really should be a frictionless system, so that's why it passes
వైరు
easily. on
బాగాలేదు
Dynaglide.
సార్ మధ్యలో ఒక చోట
The
పట్టుకుంది
wire should
Okay, then change the wire, please. Actually, put another fine cross or microcatheter and change your rotor floppy because wire,
Yeah, I
if it
think,
is kinked, that's
yeah,
what
that's-
your technician is saying. Kadandi?
Exactly, I think
Yeah.
that may be the reason why it is...
Right, right. Maybe that's why it's catching up at the break point where we are not able to.
yeah, we'll try one side, the other.
Okay.
Change the wire.
ఓకే సార్
Now the wire is moving.
And brake Peter.
Ready? Brake put it. Brake is on, no?
సార్ డైనా
Actually, the guide support is very poor because the guide is backing out quite a
Yeah.
lot.
Maybe the brake thing is not working properly here.
Ready?
Is the brake working?
Yeah, yeah. Brake, ready?
బాగా దగ్గరగా పెట్టండి.
వైర్ అయితే
It's coming out, wire is coming out. I think
Everything has come. You have to bring out everything.
Yeah, yeah.
Take out all.
Take out. Take out the wire. Advance the wire.
There's a good chance this wire
Just
would
make
have
sure
been
it's not
bent by
looped
now.
in the
change
aorta
the
as you're
wire.
trying to.
I think it's better to
Dynaglide
change
again.
everything.
Change everything.
They will change the wire. I think probably there may be some kink on the wire.
Yes.
విత్ డైనా విల్ కమ్ అవుట్
Because same wire was used for the circumflex.
సార్ విత్ డైనా విల్ కమ్ అవుట్ ఇట్ ఈస్ హోల్డింగ్ ద వైర్
Dyna,
ఇది సార్
And to take everything out. And
will take everything out. Yeah, very another wire please.
దిస్ ఈజ్ నాట్ వర్కింగ్ ఐ థింక్ హోల్డింగ్
Regular wire.
కెన్ కమ్
Go with the microcatheter and the regular wire, then put the rota wire.
yeah.
I think there's something either wrong with the brake or the wire, because the wire shouldn't be moving that much.
So for the audience sake, I think
Yeah.
follow these steps very easily. I mean, obviously, if there is a kink in the wire, try to reuse
Yeah.
for the other vessel.
Push it, push it.
Going to increase
Can
the
you
cost
focus
of
on the wire?
It is just another wire rather than doing another
Yeah.
procedure at a different time.
I think there is some kick on the wire.
Yeah, so you change new one.
The other thing is, what have you guys done when the burr is stuck? I'm sure how many of you have had burr stuck in calcified lesions?
Yeah, so I've had, whenever I don't pay close attention to, to the rotor burr, I get stuck. Once I was doing a fourth rotor for the day and I wanted to go home sooner, and then the rotor got stuck.
Here
When it gets
actually-
stuck, it's not very pleasant.
Scissor.
You can see here.
It's better to be very careful, prevent it, right from doing it slowly, and pecking motion is much better, having the wire distally well positioned.
So this portion of the wire, the burr got stuck. Actually, wire is not coming out.
Oh,
Here, it got stuck there.
Yeah.
yeah,
So
that's
here the wire is kinked, so I think just maybe now you have to pull it from the other end.
So separate it from the motor, separate the burr from the motor, and you'll be able to see the wire, and you'll be able to pull it out from there, or you can cut the wire to preserve the burr.
Or put on dyna outside the body, and you can just.
Scissor తెమ్మని చెప్పండి.
Can you pull it from the back end when you put it on dyna glide?
Yes, so it's back and inch. You just pull it up.
ఇది రాదు సార్ ఏంటి రాదు కదా కట్ చేయాలి కదా.
And other end.
You have to hold the black button in, yeah.
Dyna? It's a Dyna, no?
No, not Dyna. Dyna, I see.
No, it's not coming out.
Is the brake released?
I think it's
Yeah, the brake is released.
Yeah, the brake is released. Yeah, brake is released. Yeah, with great difficulty it's coming out.
No, it is not moving, sir.
No, not moving.
moving at all.
Yeah, it's not moving at all.
Oh.
I think it's completely stuck.
Yeah, yes.
I would change it.
Throw
I
the
think
whole
that
thing.
is the reason it was probably
Yeah, probably that
moving.
is the reason, yes.
Yeah.
Want to allow card?
Proximal and కట్ చేయండి సిజర్తో.
I would check your flush rate through the burr, because one of the reasons why the wire could be stuck within the entire burr in a lumen is inadequate flush, contrast or something gets in, blood gets in. If your flush rate is not adequate, then there's not going to be a constant flush of saline, and of course the wire can get stuck at some point within the entire lumen.
వెళ్ళిపోయాం మా ఎండ్కి.
Yeah. No, no. Come back. Come back. Yeah. From the epicranial, please. Darker. Take it to dark. Yes. Right. Show the wire tip, please. So what do you think about the RCA? RCA is really absent or?
No, I think it's probably coming from the left coronary cusp or somewhere else. I
But
thought I was with your AL1. I thought you saw something. Or that wasn't that.
But it's not
CT
filling retrogradely.
also.
Suppose if you had occluded, should fill retrogradely from the other system, and
Yeah,
not
that-
filling from the.
No, that's why I'm saying I don't think it's occluded. It's probably an anomalous
Yes.
origin.
Yes, yes.
RC?
RC.
Yeah.
What wire, please? New wire, please. So here even microcatheter also.
The
Yeah,
microcatheter is,
Where is coming out?
not going in easily.
you see that?
Yeah.
Wires coming
So even microcatheter also it's not going in easily.
Is it a fine cross or?
Yeah, it's fine.
Do you have crosshair or?
Yeah, crosshair.
But I
Crosshair
think
is good.
fine cross is the
Fine
best
cross is
for
the
this
thinnest
situation, yeah.
తగ్గండి.
Because Corsair will not cross.
Guide is this.
Here, I think the tightest area. But initially it went in, now
Maybe there's a dissection, you know, what's going on.
so what is the reason why it is not going in now? Initially we could negotiate the.
So probably some graft modification there.
Perhaps because the burr was being pushed at the calcific spot, we don't know what happened. Maybe there's a shelf-like one-way valve system. It's just not allowing anything hard going through. I think Corsair, the nose cone may wedge in a bit easily than Corsair, but perhaps it may wedge in a bit better.
No,
Yellow will
I think
engage the
Corsair
guiding
has
properly.
difficulty
Come to yellow.
crossing such kind of very tight lesions.
Caravel.
Caravel is
Uncrossable.
slightly, I mean, the same thing, but slightly better.
Yeah, it's an interesting thing. Actually, initially it crossed well, but subsequently, allow corder, please.
But if fine cross doesn't go,
Yeah, more corder.
360 degree.
Yeah, this is beautiful. At least we can see the 360-degree view of the cath lab, which is very good.
Yeah, touch, please. Guiding is not engaged properly.
Can you show us the angiogram, please?
Okay.
Both?
Now come to cranial, please.
Right.
AP cranial.
Doctor.
I think it's being demonstrated for the first time that 360 degree.
Yeah.
Yeah, I've never seen this.
Now it with the good guide support, it could cross the.
Yeah, it is crossed now.
Yeah. Take a this thing. Rota wire.
N rota wire, floppy.
Floppy wire.
I think we have about 5 to 8 minutes more, right, Dr. Srinivas?
Yeah.
Or we can go for a lecture and come back.
Are you taking another 1.25, Dr. Seshagiri, or?
Yeah, we're taking another new 1.25 bar.
Yeah. I think this room looks better than my cath lab.
Yeah. Right.
It's definitely cleaner than our cath lab.
Darker.
So, Dr. Seshagiri Rao, we'll come back to you after one lecture. Is that okay?
Yeah.
Okay, sir. Thank you.
Right.
Can you hear us again?
Yeah. Yeah, I'm able to hear. You are able to hear me?
Yeah, we can hear you, Dr. Seshagiri Rao.
Yeah. Put another rota wire and going with the 1.25 bar.
Okay.
But unfortunately, we don't have 1.25 new bar there. 1.5 is there.
I think
So-
that's fine, but you
We
know.
want to try the same bar with a new wire.
Oh, okay. You were able to get the wire out of it?
Yeah.
Okay.
But I think there is a lot of resistance. I think this bar is little.
You know, I think if the wire is stuck, sometimes the lumen of the burr itself may be having some debris in it. And
Yeah.
Ready? 1 minute, sir.
Yeah, we'll try this. Otherwise, we'll go for 1.5 bar.
yeah, I think even 1.5 is okay, but as long as you do a slow pecking motion,
Yeah.
it's stalled.
Yeah. I think the burr is jumping. Actually, you should perform a very smooth pecking motion.
Right.
But here it is jumping. Okay.
Yeah, one has to make sure there's no slack in the wire.
Yeah, there is no slack.
I mean, in the system. Yeah.
Yeah, there is no. Pressures are all right, no?
Good pressures.
Yeah. Yes. Yeah. Another. Okay.
Sir,
Ready? Yeah, see, there's
Stuck,
jumping.
stuck.
I don't know why it is jumping like this.
That means
I
that
think
there is
I'll
some
wait until
friction. There is some friction in the system.
We'll wait, patient is having,
yeah, she's having no
Vomiting, sir.
vomiting.
yeah.
The last thing we want is the bird to get stuck. So be careful. There's no slack.
Yeah. Maybe it would have been better if you had a new burr, 1.25. But this 1.25 burr, which was all used in the circumflex, it's not going smoothly.
Yeah, then
I think we should change over to 1.5, I think.
I mean, you did get through the lesion. Is it worth seeing if balloons
Yeah.
would expand at this point?
I would do that. Take the burr out, see if you can advance the balloon, a 2O balloon, and see.
Yeah.
Then,
Now we could actually cross the lesion.
right.
Raghu,
We could go across the lesion.
Chava,
I
2000.
think, we'll try another ablation, another run and see whether we can cross it smoothly. Later we dilate the lesion with a balloon. She's all right? Yeah, the pressures are around 80. Initially she was complaining of some angina. Now I think the angina is settled,
Take one
but
injection.
she has some vomitings. So what do you advise? Go with a new burr or we'll try once again this?
I would go to a new burr or a balloon. You know.
Yeah, there's something wrong with that burr. I think I would
Try a new
either
burr.
try to do a balloon or
So
We'll try another run and see, or you'll just take it out and dilate the balloon?
yeah, take it out and dilate, and then we'll come back after our lectures.
Yeah.
So thank you.
Well,
Can
yeah,
you s-
you are welcome again. Actually, with the second run, we could cross the lesion. Just show the
Minus.
minus.
One more
With
minus.
the same burr,
One more
but a
minus.
new wire. So 1.25 burr only. Go back. Yes. Yeah, this one. Yeah. Now we could think
Negative.
able to go through the lesion freely. And after this run, we dilated with a 2.5 millimeters balloon. Show the next.
Plus.
This is 2.5 into 12. Dilated the lesion part at almost 12 atmospheres. Then proximally also we dilated again. Next. So that is the result after balloon dilatation. Next we took a stent. Next. So this is the 2.75 into 33. So we kept it in the ostium. Next. Yeah. Next. So this is the inflation, stent inflation. Next. So that is the result after stenting. Yeah. After this, we took a IVS run. We'll show you the IVS run.
Okay.
Well, still there is some plaque at the lesion site. Yeah, go ahead with the IVS run. Yeah. Distally, the vessel is about 2.7 dia. Next. Yeah. Here, it seems there is some under expansion of the stent. Yes. Yes. So what do you think?
I mean, I think in the proximal portion, it just looks a little bit underexpanded. What is the minimal stent area in that?
Minimal stent area is
About
5.2, yeah. So we are dilating with a 3 balloon.
right. I mean, it's a 2.75 stent. I think you got maximum 2.9, so averaging about 2.4
Yeah.
millimeters. If you want, you can post dilate more.
Yeah, we are dilating with a 3 millimeters balloon.
Okay. So you did post dilate further.
Yeah. So this is a 3O balloon.
And that rotor burr was 1.5, right, sir?
No, 1.25.
Again, okay,
So
same
we
burr.
thought we try once more, but we
Oh,
could
yeah.
cross.
Okay. Okay.
Before taking 1.5,
Okay.
we tried.
Very good.
Yeah,
You will do there only.
yeah, go ahead.
As a rectangle. 12.
Go up to 12.
12.
How many atmospheres?
12, sir.
It's going up to 12, we're going up to 15.
Sir, this is 3.
Yeah,
14, 15.
yeah. It should go good. Go approximately.
Yes, sir. Hello, card.
Yes, go ahead. Go ahead.
12,
Up to 16.
14,
So
16.
Yeah. Into level card. Patient is fairly stable after the LED was stented.
right, your blood pressure is also good. I think you
Yeah, blood pressure has improved. Yeah,
achieved an excellent result.
yeah. Her angina is totally settled.
More earlier woman.
Chest.
చేయి తీయాలి.
Chest. Chest, please.
Not very clear.
Yeah, things should go. Inject.
Ready, sir.
Go. Should go already.
Okay, sir. Hold
Okay,
it.
right. Elect. 16, 17.
I thought you were outside the vessel.
I don't think. You will inject MC once. Just inject. Take another injection. Or you can show the later. C minus.
AP card will take otherwise.
Yeah. Here.
Yeah.
It's exactly the
Right,
stem.
right. Yeah, that's okay.
Yeah.
But you have to go high pressure there, I think.
Yeah, going up to 18 atmospheres.
More, maybe it's still under deployed.
Okay. Go up to 20.
See the
18, 20.
Yeah. Okay. Deflect. Yeah.
one final angiogram and
Yeah. So it's initially we thought it's a 2.5 vessel, but after dilatic deletion, the vessel size has increased. Actually, it's a bigger vessel.
right.
Ready?
Within the stent. Ready, sir.
That looks good. Okay, Dr. Seshagiri Rao, a very nice demonstration of a rotor in a very difficult case
Yeah.
that you have done.
Yeah, thank you very much.
Thank you very much.
Thanks again for wonderful transmission. So.
Yeah.